Welcome to our mask ultrasound Zoom meeting today. And we are so privileged to have a very distinguished speaker and a good friend. He is right now in Seattle, Washington, and reading through his bio. There's just a lot of information here, but I'll just pick up the most important one. He has been a clinical instructor of different clinics and of course centers and institute. He is an assistant professor of the Department of Physical Medicine and Rehabilitation, University of Michigan in Ann Arbor, Michigan. He is also the present medical director of the Comprehensive Musculoskeletal Center, University of Michigan. And he is also the attending physician of the Swedish Medical Group in Seattle, Washington, a current medical director of sports and performance medicine, Swedish Medical Group in Seattle, Washington. He has written a lot of book chapters in different books on physical medicine, rehab, and other related textbooks, and also has written a lot of different scientific journals and papers talking about different topics on PM&R. And I'm so happy and privileged to introduce to you a friend and a colleague, Dr. Troy Henning. We welcome you, Dr. Troy, in our group today. And before we begin, let us just bow for a moment for a short prayer. Heavenly Father, we thank you for your grace. We thank you for your goodness. We thank you for preserving our lives amidst these COVID challenges and all these things that's coming up. And in our country also, amidst the storm, we ask, Lord, that thou wilt spare our lives and give us good health and strength, and that no harm will come upon us. We especially pray for Dr. Troy as he delivers his lecture to us, that we will learn things that will help us in our dealing with our patients and also in improving our skills and our knowledge. Thank you for your grace and your goodness today and your forgiveness. In Jesus' name we pray. Amen. So Dr. Troy, welcome. And we are so honored to have you as our speaker today. So you can go.
Oh, great. I appreciate the introduction and the invitation. After hearing who you've already had and who you may have speak in the future, it's a great honor to be part of this. So thank you very much. So I was asked to talk about diagnostic ultrasound and some ultrasound-guided procedures as it relates to the wrist and hand region. We'll go over common injuries that would occur both on the dorsal and volar aspect, as well as some commonly performed ultrasound-guided procedures of the region. I have nothing to disclose. So first, we'll start off talking about the dorsal aspect of the wrist and hand, and then switch our attention to the volar region. And then along the way, there's going to be some scattered ultrasound-guided procedures targeting specific areas. So as you know, the dorsal wrist, joint-wise, we kind of break it up into the wrist joint, right? So the wrist joint is broken up into the radiocarpal joint, which is the joint between the radius ulna and the proximal carpal row. And then you have the mid-carpal row between the proximal and distal carpals. And then you have the distal radial ulnar joint, which is the distal joint between the radius and ulna. And it's separated from the radiocarpal joint by the triangular fibrocartilage complex. Further down in the hands, you'll have the commonly you'll see people with arthritis at the metacarpal or STT joints, a little less commonly at the MCP and IP joints of the fingers. Some commonly interrogated ligaments include the ulnar collateral ligament with the thumb, as well as the scapholunate and lunotrochlear ligaments along the dorsal wrist if you're concerned about instability. There's also tendons along the dorsal aspect of the wrist. They're broken up into compartments, going from radial to ulnar, numbering 1 through 6. And then on occasion, you'll also want to look at the superficial radial nerve. This slide shows the dorsal wrist recesses. We'll start with the drawing at the top right of the screen here. As you see, it depicts the radiocarpal as well as the midcarpal joints. The kind of tannish areas represent the dorsal recesses of those respective joints. The ultrasound image below them also shows an effusion with dorsal recess emanating from the radiocarpal as well as the midcarpal joint respectively. They have a sort of a lenticular or kind of lunar shape to them when they're effused. Without fluid in them, it may be challenging to see the recess itself. If you look at the bottom left image, ultrasound image, you'll see the distal radial ulnar joint. Here, this is a cross-section or short axis view of that with the radius on the right of the image. The curved arrow points to the joint. The other landmark for the joint would be the fifth compartment, or the extensor digiti minimi tendon. It immediately overlies the joint recess. The image, ultrasound image in the middle depicts a ganglion cyst, often along the dorsal aspect of the wrist. You may see pockets of fluid emanating from the dorsal recesses of these joints, specifically between the scaphoid and the lunate. This is the most common region of the wrist where you would see a wrist ganglion. The image above that simply shows the normal appearance scaphoid and lunate bones, as well as its intervening scapholunate ligament. The recesses of the midcarpal and radiocarpal joint can be easily accessed. Usually we move from a distal to proximal direction into the target recess, either within or out of plane relative to the transducer. Usually there's a window through by which you can pass around the tendons, so you don't necessarily have to pass directly through the overlying tendons to access these joints. If there's a ganglion cyst present, then you would easily target that by usually coming from either a radial to ulnar or ulnar to radial, depending on which way would allow you to access it most safely. The distal radial ulnar joint can also be easily accessed. If you look at the right image, the right sonographic image, you'll see the injection being performed. It's easy to visualize the needle and the joint if you use a generous gel standoff technique. So at the top right corner of the image, you'll see a lot of gel here overlying the skin. We find the needle in that gel and then bring it right down into the joint, just deep to the extensor digiti minimi tendon, which is depicted by that asterisk. Moving a little bit further down to the hand, you have the carpometacarpal joint, which is going to be the most common symptomatic joint in the hand that you would inject, often in a middle-aged, typically female patient. They'll complain of circumferential basilar thumb pain. Here's a radiographic image of that joint in the center, and then the sonographic appearance of that region is just to the right of that. The green triangle represents the joint recess. The little red circle to oval represents the radial artery, which is in a nearby area. This joint can be easily accessed in or out of plane relative to the transducer, which we'll demonstrate in the next slide. The triscaphoid joint, which is the joint between the scaphoid, the trapezium, and the trapezoid bone, is more commonly bothersome in the male patient. They'll often present with basilar pain, but it'll be a little bit closer to the second ray where they point to. Again, this can be easily seen on ultrasound imaging. Again, the green triangle represents the dorsal recess of that joint. This time, the radial artery is a little bit closer, so you definitely want to pay attention to that structure. Here's ultrasound images representing how you could approach injecting these areas using both an in and out of plane technique relative to the transducer. The sonographic image to the left shows the in-plane technique. Here, we're moving from a dorsal to volar direction. I find this to be less painful as the dorsal region of the joint has less innervation than the volar aspect. similar as how we may approach the thenar muscles from an EMG standpoint. You'll also see there's a little bit of a gel standoff here, which allows us to find the needle easily in the gel and then bring it straight down into the joint recess. The needle here is depicted by the green arrows. The out-of-plane technique would be approached similarly. This time the needle is brought in short axis relative to the transducer, moving from a dorsal to volar direction, with the tip of the needle being seen here as an echogenic structure within the center of this red oval line here. And then you just look for it within the recess and then slowly inject. These are obviously small. They do not would usually start with a mixture of half a cc of anesthetic and half a cc of steroid or a small volume of orthobiologics. And I may only get half of that volume injected. I'm feeling for the pressure as I'm injecting to make sure I'm not over pressurizing it, because if I do, then they just leave unhappy. The metacarpal phalangeal joints as well as the interphalangeal joints are approached in a similar fashion. Because these are so superficial, I find it most easy to target them using the out-of-plane technique. So this box up here with the finger shows the orientation of the transducer. The red arrow would be the direction of the needle. The green arrows of the sonographic images represent the joint recess where the needle tip would be placed for either aspiration or the injection. Moving back to diagnostic evaluation of the dorsal wrist. On the left image, it depicts the sonographic appearance of the normal scapholunate ligament. It's this normally hyperechoic fibular pattern structure spanning the recess between the scaphoid and the lunate. The ultrasound transducer would be placed axial relative to the wrist, roughly just distal to where Lister's tubercle would be palpated on the back of the radius. The lunotriquetral ligament is also a compact fibular structure, hyperechoic in nature, connecting the dorsal aspect between the triquetrum and the lunate. As you recall, and if you look at the radiographic image in the center bottom of the screen, the shape of the wrist is curved, and so you have to orient the transducer at a slight oblique axial orientation in order to see this ligament more easily. If you came at it straight axial as you would for the scapholunate ligament, you'd be cutting across it and would not be able to visualize it quite as well. On occasion, you'll have a patient coming in with most often acute thumb pain. They usually report having fallen, having had their thumb caught on an object causing extreme abduction or valgus load on the thumb. It'll often be quite swollen, ecchymotic in appearance. They're a little reluctant to have you evaluate it from a physical exam standpoint. So that would be called a skier's thumb or an acute ulnar collateral ligament injury. On occasion, you may have a patient that does a lot of heavy, regular kind of manual twisting work where they're loading the thumb through an abduction kind of force on a regular basis, and they'll stretch that ligament out over time, causing more of a chronic injury. If you look at the radiographic image, the red half circle shows the relative position of the ligament. As you recall, it moves from the first metacarpal to the base of the proximal phalanx of the thumb. When these are injured, they're often injured from at the distal aspect at their insertion and may either be a pure ligamentous injury or involve bony injury where they have an avulsion of the ligament. They're quite easily seen on ultrasound because of the superficial location. You do have to sort of roll the transducer in and point directly at the ligament to see it easily. Often on the phalanx, you'll find a little kind of notch where the ligament kind of settles into. Overlying the ligament is the aponeurosis of the adductor pollicis. This, as you recall, is a muscle that spans the first dorsal web space, moving from the second metacarpal over to the thumb, and it connects into the thumb and into part of the extensor tendon of the polycis. Nonetheless, it overlies the ulnocollateral ligament here and is depicted by this somewhat hypoechoic structure above the ligament. I'll play the video here, and I'm moving the distal phalanx to make the aponeurosis a little bit more conspicuous, and you can see it sliding across the top of that ulnocollateral ligament. This is an important structure, as if the ulnocollateral ligament completely tears, it may retract from a distal to a proximal direction, and then that aponeurosis would fall down in the gap and prevent healing or scarring across, creating the so-called Stenner lesion. Also on down, it allows for assessment of the ligament. Here you see the valgus load placed on the thumb, and we're interrogating the integrity of the ligament. I can tell you from the few of these that I've seen, they're quite painful, like I said before, and you have to be really efficient, and you may only get 1 or 2 chances to stress the ligament before the patient sort of had enough. Moving on to the dorsal wrist recesses, again, there's 6 compartments numbered from radial to direction. The first compartment here is in purple, and it's the most radial is the abductor pollicis longus, followed by the extensor pollicis brevis. The extensor radialis longus, followed by the carpal radialis brevis. The third compartment, just ulnar to Lister's tubercle, is the extensor pollicis longus. The fourth compartment comprises extensor indices as well as the extensor digitorum communis. The fifth compartment immediately overlies the distal radial ulnar joint and is composed of the extensor digiti minimi or quinti. And then the last or compartment is the ulna in a little fovea, and it is the extensor carpi ulnaris. These are usually interrogated one at a time, and I usually start from the first and move all the way over to the sixth sequentially. Some regions of the body, as you know, are more easily interrogated in their short or cross-sectional area. Usually these are tubular type structures, such as these tendons. This first radiographic image, ultrasonographic image shows the adductor pollicis longus, extensor pollicis brevis tendons. To orient you, the right of this image is radial. This is the radius you see here, and then the tendons are moving from distal to proximal as the video plays. The second compartment is overlying the radius. Again, that is the extensor carpi radialis longus and brevis. They insert into the base of the second and third metacarpal, respectively. The third compartment is the extensor pollicis longus. Again, that is a tendon that lives just ulnar to Lister's tubercle, which is this bony prominence right here. And it moves along the back of the radius and then crosses over the second compartment tendons here, and then we'll go all the way down to the base of the distal phalanx of the thumb. So it's this small oval hyperechoic structure that you see moving from an ulnar to a radial direction as this video plays. The fourth compartment, again, is the extensor digitorum communis and indices. It also contains the distal aspect of the posterior interosseous nerve of the forearm. I'll stop this video here and I can show you those structures individually. So the extensor digitorum communis are these tendons. I made the extensor indices here anisotropic to make it a little bit more conspicuous to see here. And then at the very, just deep to that is the posterior interosseous nerve. So while you look at this, I would play that a few times so you can try to sort out those individual structures there. The fifth compartment, again, is the extensor digiti minimi and directly overlies the distal radial ulnar joint. So if you're having a hard time locating it, the distal radial ulnar joint may serve as a good landmark for you. But it is this structure here. It is relatively oval, flat, and should be hyperechoic. moving from a radial to ulnar direction here on this video. And then lastly is the sixth dorsal compartment. That is the extensor carpi ulnaris tendon. Again, it runs along the ulna down to the base of the fifth metacarpal here. It's in a little sulcus along the dorsolateral aspect of the ulna. The first and sixth dorsal compartments are most commonly involved clinically. These slides here, these images here show decorative veins, tenocynovitis, which is an entrapment tendinosis of the first dorsal compartment tendons. This first left ultrasonographic image shows the abductor pollicis longus and extensor pollicis brevis tendons here. Overlying them is the retinaculum that overlies them that helps form the roof of the first compartment. It is here, it is thickened in this patient. They have decorative veins tenosynovitis. Often this retinaculum can be, in the normal asymptomatic subject, would be difficult to see completely. When it's thickened like this and they have symptoms, it would correlate with decorative veins. Often the region right above or around the level of the extensor pollicis brevis is often much thicker than it is over that of the abductor pollicis longus. Usually you will not really see a lot of Doppler signal in the tendon sheath because it's not really an inflammatory problem. It's more of an entrapment of these tendons between the retinaculum and the underlying bone. You may see a tendon sheath effusion, but it isn't generally inflammatory. On occasion, a patient may also have a septation of this compartment. That's often depicted by, if you look at the dorsal aspect of this radius, it's not straight across. A normal one would be straight across. When they have a septation or a subcompartment of this compartment, they'll often have this bony prominence here, and then coming down from the retinaculum is an arm or an extension of that retinaculum, which separates the two tendons. So in a sense there, it's the first compartment is subdivided into two separate compartments in this particular patient, and it may make them more prone to this problem. This is the sonographic image on the right. It's a long axis view of the same patient. Here you see the tendons, here's the radius, and then overlying it is the thickened retinacular structure. Corticosteroid injections are commonly performed for this particular diagnosis. They can be done in plane with the transducer, short axis to the tendons, or in plane to the transducer, long axis to the tendons. It's somewhat up to the person performing the injection. There is no wrong way. You do have to be mindful that the superficial radial nerve is often nearby, if not sometimes overlying the region where you'd be injecting, so you do have to trace that out prior to the injection. As I mentioned previously, the sixth dorsal compartment would be the second compartment that would be commonly involved in patients. They may have pain or subluxation of this tendon. They may have an entrapment tendinopathy as well, and you may see a tendon sheath effusion here. This compartment can be easily targeted via an injection. I usually have the patient either lying or sitting with their palm down on the table. I then apply the transducer along the ulna, looking at the ulna and tendon and its short axis, and then I'll use another gel standoff and bring the needle from dorsal, moving volarly, and either go above or below the tendon, getting into the sheath. This allows for easy control of the transducer, the hand, and the needle, because everything's nice and stable on the table. In addition to injecting the first dorsal compartment, you can release it using sonographic guidance. So what was once typically just an open surgical procedure can be relatively easily done in an office setting using a needle or other various tools such as a surgical thread. Here, this top left image shows how we would anesthetize the area first. We come from a distal to proximal direction, in plane to the transducer, as well as long axis to the tendon and the retinaculum. We'll anesthetize the skin and the tissue around the retinaculum to make it more conspicuous and obviously help with pain control during the procedure. The needle is brought in immediately overlying the center of that compartment, so somewhere between the adductor pollicis longus and extensor pollicis brevis tendons. That's shown here in this top right image where the video is playing. It's the needles being brought in short axis in this case. And then we use this needle called a no-core needle. It's basically a needle that pharmacists use for mixing medications. At the end, it has a little blade. It almost looks like a little X-Acto knife at the end. And then it has a little side port through which they would just, withdraw or inject the solutions that they're, making. So here it is being brought in under ultrasound guidance. You see the blade here, and the blade is directed up at the retinaculum. And then we're sort of pushing it through and making a little kind of sawing kind of motion with that needle and feeling it inside the retinaculum. And then once we're all the way through, then the procedure will be completed. And this almost always leads to alleviation of their symptoms. This is commonly performed in your peri or retirement age grouped person. It's usually someone that's changing how they do things and is aggravating those tendons. Your postpartum patient doesn't really have a thickened retinaculum. They have just more kind of fluid overload, and they respond nicely to the steroid injection. So that's sort of how I break out those two populations. As I stated before, the extensor carpal ulnaris sometimes can be subject to subluxation or dislocation. The retinacular structure that maintains its orientation along the ulna there can become disrupted through trauma, and you can, through dynamic assessment, see the tendon either sublux or frankly dislocate. It moves typically, most commonly in a volar direction, either during supination of the forearm or flexion of the wrist. This picture or diagram to the right here is taken out of this article where they measured the normal excursion of the tendon relative to the sulcus here on the side of the ulna. You should note that it does move out of the sulcus a little bit. So a small amount of migration, up to about 40% the thickness of the tendon out of the sulcus is normal. So you wouldn't want to overcall that problem in those individuals. This cine loop here depicts the assessment of that. This is a normal subject. This can be a little tricky. Typically, you would have the patient's elbow or arm on a table or a stable platform. The elbow is flexed to about 90 degrees. And then the transducer is cupped around the ulnar side of the forearm while your non-ultrasound hand is controlling the wrist and forearm, where you can flex the wrist or supinate their forearm while you're taking the video. If you have them do it, you're going to have to coach them through it because they're apt to just do it quickly, and it's really hard to stay on top of this structure in that case. Other problems that may arise along the dorsal region of the wrist and forearm as they relate to tendons could include intersection syndromes. These are typically people that engage in a lot of repetitive supination, pronation of the forearm, or some weightlifters, such as those that use kettlebells, rowers would be the other common group. They develop kind of a friction syndrome between the compartments that are crossing over one another. So the first dorsal compartment, as it migrates from a proximal to distal direction, will overlap the second dorsal compartment tendons. I'll play this first cine loop and you'll see that happen. So the more superficial tendons here are the first dorsal compartment tendons, which are the adductor pollicis longus, extensor pollicis brevis, and they're moving over top of the extensor carpal radius longus and extensor carpal radius brevis tendons here. This is along kind of the distal 1/3 of the forearm. They would have pain there and maybe some crepitus. If it was bad enough, you may see a tendon sheath effusion as well. A little further down, overlying the dorsum of the wrist and hand area, is where the third dorsal compartment will cross over the second. We saw that when we were looking at these individual compartments. I'll play this cine loop again. So again, the third compartment moving over the second. So I stopped the loop here. So this is your extensor carpi radialis longus tendon, extensor carpi radialis brevis tendons here, and this small, thinner, kind of more oblong tendon here is extensor pollicis longus, moving back and forth across those other two structures from a proximal to distal direction. Right? So you can kind of slow that down and see that those orientation of those structures. So these, outside of modifying activities, you could inject corticosteroid around them. I don't do that this frequently. I just don't see this problem that often. I may have seen it, once or twice in the past 14 so years. But nonetheless, they can be approached from a variety of directions, but I think most easily it would be done short axis relative to the structures, because you can see the tissue plane between the different compartments, and then you would just have to bring it in. Usually long axis, I think, would be easiest, moving from a radial to ulnar or ulnar to a radial direction, just being mindful of any potential nearby neurovascular structures. We don't want to pass through them. I think it would also lend well to the gel standoff technique, making it a good entry point for the needle and then straight across in between the respective tendons. Moving further down into the finger, as you recall, the dorsal aspect of the finger is quite complex. You have a central tendon, more or less, coming down to the extent of the extensor carpi, or extensor digitorum communis tendon, inserting into the base of the middle phalanx. You have lateral tendon slips coming from the lumbricals on the volar side of the lumbricals and interosseous membrane muscles of the volar side, coming down and going all the way down to the base of the distal phalanx. There's some retinacular structures that kind of keep all of this complex anatomy in place. So there's lots of stuff happening back here. Much of it is very small and hard to see. And so you really have to have a firm understanding of these areas before interrogating them. If you tear the central slip, you'll end up with extension lag or weakness of the middle the proximal interphalangeal joint here. So they just won't be able to extend there. If this retinacular structure overlying the level of the metacarpophalangeal joint happens, you can get subluxation of the tendons or deformities. So a lot of things can arise here. This was an interesting article that it did, I thought, an excellent job describing some of this more complex anatomy. This figure here is taken right out of that article. So the darker center is the metacarpal. This sort of yellow oval is connective tissue. This lighter yellow is the extensor tendon, and then the dark lines here represent the retinacular structures that kind of envelop the whole dorsal construct and then connect into the volar plate on the palmar side of the hand. It's sort of broken up into a ulnar and radial aspect as well. The first top ultrasonographic image shows this same anatomic construct here. This is the metacarpal. Here's the connective tissue. This is the extensor digitorum communis tendon. And then you have the ulnar and radial sagittal bands, which are these darker structures here. It's those sagittal bands which are really the stabilizing force for your extensor tendon. And if you tear typically the radial sagittal band, it'll lead to ulnar subluxation of the extensor tendon, and they'll get painful snapping or subluxation of that tendon over the back of the MCP joint as they flex. in order to see this anatomy well, you have to use an abundant gel standoff technique to see it cleanly, and it's going to be dynamic as well. So that really helps keep your transducer centered over the area as the motion occurs. But more or less, you want to see normal with the extensor tendon would stay in the center. In the abnormal aspect, the retinacular band would be ruptured or incompetent, and then the tendon would migrate, typically in an ulnar direction. Coming down to the superficial radial nerve, this is injured in isolation on occasion, either iatrogenically through IV placement or infiltration of IVs. It can also be subject to ligatures. So if there's a tight band around the wrist or handcuffs, that's often called chiralgia parasitic or handcuff palsy, because of the superficial location of the nerve and its immediate location also to the radius here can be compressed and cause pain or paresthesias, dysesthetic pain along the back of the radial side of the hand. It's often also referred to as Wartenberg syndrome. There's a couple of important tendons to realize where this nerve lives. If you're having a hard time finding the nerve, it lives and comes up from a deep to a superficial location between the extensor carpi radialis longus tendon and that brachioradialis tendon. So the nerve is depicted here. You see the kind of 4 or 5 fascicles lined up here. That's the superficial radial nerve. This, we had the honor of having a really high ultrasound frequency transducer available to us for a little while. So we were playing with that, trying to see if we could figure out some use for it. But nonetheless, this is a 70 megahertz transducer. So it's something you may not necessarily have access to commonly, but it really allowed for, good interrogation of this nerve. So, you know, you can see all these individual fascicles of this nerve. It looks huge, but as you saw on the other normal transducer, I'll call it, you know, it's not that easily seen. So I'm going to play the cine loop here, but again, recall this is the extensor carpi radialis longus and brachioradialis tendons. The nerve moves from a deep to a superficial location between those tendons and can be subject to compression either by those tendons or external ligature, or, you know, if they're accessing the vein nearby, they may accidentally poke the nerve, right? The other important landmark here, I think, is this brachioradialis tendon. It actually goes down and forms the floor of the first dorsal compartment tendon. So as the video plays, I think it's this one. Yeah, it's this one. It goes down. You see it going deep to the first dorsal compartment tendons, and then it's going to insert onto the distal radius. So you may not typically see that on your normal ultrasound transducers, but because of the frequency range of this, it's easy to see that anatomy there. There's a couple of times you're going to have a patient come in, they say they have this mass, it's been there for a while, they feel like it's getting bigger. Usually I see this in an adolescent brought in by their parent where, you know, all of a sudden as they're maturing, getting bigger, things are getting bigger, and these accessory muscles become more noticeable. And so it's just a matter of understanding that they're possible to occur. Often, if they are present, they may occur about a third to half the time bilaterally. So this one is the extensor digitorum brevis manus, usually coming off the dorsal aspect of the radius, most often going down, inserting to the tendons going to the index finger. Sometimes there's singular or multiple muscle tendon components to it. Sometimes it may also go down into the second or the digit or the long finger. The ultrasonographically would appear as an extra muscle. So the normal architecture of the muscle would be there. The sternite appearance in the cross section would allow you to identify it as muscle and be confident that it's a muscle, and then obviously you can have them contract it and see it moving, and be confident it's not something tumor-wise. Moving on from dorsal, we're going to move on to the volar wrist. We'll talk about carpal tunnel and Guillen's canal, the finger flexor tendons, presence of ganglion cysts. Down in the fingers, we'll talk about the pulleys for triggered fingers, touch a little bit on tenocynovitis, flexor tendon injuries, and then again, talk about some anomalous muscles, and then lastly, tumors. So most commonly, you're going to be looking at the volar wrist probably for carpal tunnel syndrome or median neuropathy at the wrist. As you recall, it has the 9 tendons and the nerve within the tunnel. Proximal is bounded by the scaphoid and the pisiform distal tubercle trapezium and hook of the hamate, with the transverse carpal retinaculum overlying that, forming the roof of it. On the ulnar aspect, you'll have the ulnar neurovascular structures. Here's the ulnar artery and nerve that's sort of in its own little tunnel, with the palmar carpal ligament forming its roof and the transverse carpal ligament forming its floor as the entrance to Guillen's canal. Typically, the median nerve would be found a little bit more on the radial aspect of the carpal tunnel. It should be also located superficial relative to the tendons. Again, ultrasonographically, the entrance, you have here, the left is radial or thumb side of this image, top is superficial. So the purple represents the transverse carpal ligament. You can see the median nerve, it's a little bit right to center overlying the tendons. Distally, this dotted yellow-green kind of line here represents the distal aspect of the transverse carpal ligament spanning from the tubercle of the trapezium to the hook of the hamate. You should note that the transverse carpal ligament is multiple layers, but also thicker along its distal aspect compared to the proximal region. We can use ultrasound. I think this a little bit for debate, but some people are using ultrasound to assess for carpal tunnel syndrome. I think that's okay if it's clear that they have carpal tunnel syndrome and not something else. Obviously, EMG would be better ruling out or assessing for competing diagnoses. But nonetheless, it is a tool to at least look for the presence of carpal tunnel syndrome. Typically, we measure the cross-sectional area of the median nerve. There is some different numbers in the literature, but greater than 9 square millimeters, the nerve would be relatively big and concerning for median neuropathy at the wrist. You can look at the cross-sectional area change between the proximal 1/3 of the pronator quadratus compared to the maximal area of enlargement within the carpal tunnel. And if that difference is greater than 2 square millimeters, has a fairly high sensitivity for the presence of carpal tunnel. Doesn't really speak to the severity. There are some studies where they look at remarking about the severity relative to the size based off of comparative EMG data. That's this table down here at the bottom right. So I'll use it and we'll look at it and measure it and make note of it, but I still feel like there's probably a better role for EMG in most cases. Other things beyond the cross-sectional changes that would be associated with compression of the nerve would be this thing called a notch sign. So basically, the transverse carpal ligament is pressing down on the nerve. The nerve is swollen proximal and distal to the carpal tunnel, and so it has this kind of squashed appearance of it on the long axis view of the nerve. These sonographic images to the right are showing how and where you would measure the cross-sectional area at the proximal level of the pronator quadratus, as well as the maximal area of enlargement in the carpal tunnel. Again, the difference, if it's greater than 2 square millimeters, it would be consistent with the presence of carpal tunnel or median neuropathy at the wrist. On occasion, you'll find different appearances of the median nerve, right? So you can have a bifid median nerve, which is shown here in this cine loop So these usually start fairly high, and we typically see them down here at the wrist because that's where we're looking most often. Often they'll be accompanied by a persistent median artery, which comes off the ulnar artery up in the forearm, really at the level of where the anterior interosseous nerve is arising off the median nerve. So you can trace this all the way down from that level. If this is present, and you're measuring the nerve, you'll need to measure both aspects of the nerve. You can't just take a single kind of circumference measurement. You have to measure the individual nerve components there, and then add them up to get your number. Obviously, you can perform carpal tunnel injections. I learned it from using this technique where moving from an ulnar to a radial direction. Again, using a bit of a gel standoff technique, I think helps get over the ulnar neurovascular structures. You can easily see all these structures, and then using ultrasound, obviously you can place the solution superficial or deep, or make a circumferential kind of flow pattern around the nerve. Now that I've been out a while and I've done some carpal tunnel releases, I don't do this so much. I just come from a distal to a proximal direction as if I was going to approach it from doing a release and inject it that way. I just find it's faster, and I feel like patients tolerate it better. You wouldn't want to necessarily come from the radial aspect. You have the radial artery over here, but also you have the palmar carpal, so the palmar cutaneous branch of the median nerve coming off on the radial side. So there's too many things on the radial aspect that could be easily hit by accident. So don't come from the radial aspect. Potentially newer concepts for ultrasound guidance is carpal tunnel release. This has been reported frequently in the literature using a variety of different either surgical tools or things that are designed specifically for carpal tunnel release, even a surgical thread type device, or just simply needles. So far, there hasn't been any major injuries that have been reported as far as I understand. Using most of these, I haven't seen any, like with the Manos or hook knife or Sonix, there hasn't been abundant amount of patients needing to be converted to a surgical release, meaning they're working quite well. And based on what's been reported thus far, patients are responding similarly as they would for open or endoscopic release as far as their outcome measures go, with similar turnaround times or improvements in the symptoms after these releases. This is just an example. I'm not necessarily saying that it should be done only with this device. Is just an example of a tool that can be used for carpal tunnel release. Can be easily seen under ultrasound guidance, placed into the carpal tunnel in a safe way. It has some inherent built-in features that make it potentially safer to perform, where there's some saline balloons that can be filled, pushing the median nerve further away from the knife of the device, and making it very hard for you to hurt someone. Here is this top right picture, shows the tip of this device blown up. These cylindrical things running down the length of the device are the actual balloons. They fill up with saline, and that's what you're seeing at this bottom sonographic image here in the center column. That's the saline balloons filled up, and then this large arrow represents where the knife would come up out of the device. So it's really far from the median nerve and the adjacent ulnar neurovascular structures. And it's all done through a very small incision above the level of the wrist, or the weight-bearing region of the wrist anyway. So, I think for a lot of our rehab patients that use ambulatory aids or use their hands to transfer, this, I think, would be a really nice choice for them over an open technique where, they'd be pressing down through the wrist over the incision. Here's a couple of videos showing how that's performed. So under under sonographic guidance the entire time. The device is brought down into the tunnel. Once it's in the right location, those saline balloons are inflated with the saline. So here you see them filling and pushing the median nerve further away from the center of the device where the knife would come out. Here's a little picture of the knife, it's basically a hook knife. It comes up out of the device. Here it is, and it's in the transverse carpal ligament. And then the image to the right here will be the video. You'll see it pop up and then boom, cut through the ligament, and then it's all finished. And then at the conclusion of the procedure, the device is sitting superficial to the landmarks of the carpal tunnel, showing you that that ligament has been completely cut. So it's nice from start to finish. If you're doing these more advanced procedures, again, not only the bifid median nerve, but there are, anatomic variations of the thenar motor branch of the median nerve. So obviously not part of it that you want to injure at all. You could really lead to a lot of problems for that patient, not only pain, but functional wise. And that can be very challenging to repair if it is injured. This, again, kind of high resolution ultrasound here shows the thenar motor nerve coming off and then migrating up through the transverse carpal ligament. So usually it comes off distal to the transverse carpal ligament. In this case, it's migrating up through the transverse carpal ligament. And in this case, this patient probably be safer to have this carpal tunnel released by a normal open surgical process where they can sort of dissect this out, make sure it's not injured, and not put tension on it, after a release. So you have to know, obviously, what you're looking at and what not to hit and when not to do the procedures. Here, this long axis view of that same nerve coming up through the transverse carpal ligament. So it takes a while to learn how to find that nerve, and it's obviously not that, here it looks easy, but it's not always that conspicuous. So again, here on that really high resolution ultrasound, you can see this thing much more easily, where it's coming off the median nerve, migrating from ulnar to radial direction, and then coming up through the transverse carpal ligament. So lots of different directions and positions for this nerve. And that's something that you'd want to hit. Here it is in its long axis again, coming up through the transverse carpal ligament. Moving on to Guillen's canal, as you know, that's where the ulnar neurovascular structures would pass through from proximal to distal direction. Pisiform would be ulnar, hook of the hamate. Distal would be on the radial aspect of that tunnel. The roof, again, is the palmar carpal ligament. The floor is the transverse carpal ligament. It's divided up into zones, as we know. Zone 1 is the mixed or motor sensory. Zone 2 is the motor component. I remember this because there's motor is a 2-syllable word, right? So zone 2, motor. And then zone 3 being 3 syllables, so sensory is the third one. This top sonographic image is the entrance to the Guillen's canal, so ulnar artery nerve, and then here's the pisiform. And then distally, you have the hook of the hamate to see the kind of hyperechoic kind of top, and then the shadow below it. And then the sensory nerve often immediately overlies that hook of the hamate. And the motor nerve is diving deep down here. It's already in the hypothenar muscles over here. Things to watch for when you're looking within Guillen's canal is to look for dangling cysts that may cause compression or aneurysms of the artery, or as we'll see later, accessory muscles. So the accessory abductor digiti minimi may overlie the tunnel and then cause compression from an extrinsic kind of aspect. Finger flexor tendons, again, there's the 9 tendons, so the 4 FDS, 4 FTP, and then the flexor pollicis within the tunnel. You're looking for tendon sheath effusions or tenosynovitis. On occasion, you'll have a patient that may have ruptured a tendon, or maybe they had surgery and the surgeon wants you to see if they have re-ruptured one of these tendons. The flexor carpal radialis tendon from like a non-surgical exposure kind of risk can be injured when they have arthritis along the basilar thumb region. So the tendon immediately runs over top of the scaphoid, and if there's osteophytes along the scaphoid, it can cause attritional injury to the tendon and rupture or tendinosis that way. And then, as you recall, the FCU, it does not have a tendon sheath because it runs directly down into the pisiform bone, but it is a site for calcific tendonitis, so calcium hydroxyapatite deposition within the tendon. Usually presents somewhat like gout. It'll be red hot, kind of swollen. It's usually clinically apparent what's going on and may be depicted radiographically as well. This is just an example of volar wrist ganglion. So the ganglions, again, occur more commonly on the dorsal aspect, but on the volar aspect, they occur more commonly on the radial aspect of the joint, coming out of the radiocarpal joint. They'll often kind of sneak up around or encircle the radial artery. Because of its adjacency to the artery, I often shy away from aspirating these because you have the median nerve on the ulnar aspect of it, the radial artery on the radial aspect, are somewhat entwined in the cyst, and I think because of the relative high recurrence rate with aspirations, I just refer these patients on for more definitive care. But nonetheless, looking volarly, look for the ganglion cyst mostly on the radial aspect of the wrist. Moving down to the fingers, you have the pulleys. They're retinacular structures. They hold the FDS, FTP tendons adjacent to the underlying bone to allow a greater degree of excursion of the tendon, which then allows for a greater degree of flexion or bending of the respective joint. Clinically, the most common problematic tendon pulley would be the A1 pulley. That's at the level of the metacarpophalangeal joint. It becomes thickened and similar to De Quervain's, basically pinches or crushes the flexor tendons against the underlying bony structure and then causes injury to the tendon or tendon sheath effusion. And then, as you recall, they'll report pain as well as potential triggering or locking of the respective digit. The more distal pulley or retinacular structures are more injured traumatically. A2 or distal would be more injured in a climbing type mechanism, so rock climbers, etc. They put a lot of tension through these, and they'll basically tear the tendon up through the retinaculum. That'll cause pain, obviously, but also a lack of ability to flex the finger in those patients. And if they injure them, they'll often need to have those repaired. There's generally 5 retinacular structures for the fingers, and then 3 for the thumb. Again, if you rupture the pulley mechanism, it will lead to this phenomenon of bowstringing of the tendon. So the normal kind of appearance of the area sonographically is this top sonographic image. The tendons are immediately adjacent to the underlying phalanx. When the retinaculum is torn, then the tendons are allowed to float off or bowstring off the bone. Even at rest, sometimes you'll see this. So if you see basically pretty much any degree of fluid between the tendon and the bone, it really would, it's probably not normal and represents tearing of the retinacular structure or that pulley. There is a suggestion to look at these retinacular structures at different degrees of flexion of their respective joint. So from this article, they recommended 45 degrees of flexion of the PIP for the A2 and 10 degrees for the A4 pulley. Here's just some cine loops looking at normal tendons here, just so you can see the excursion of the tendon quite easily. This is my finger, so these are normal retinacular structures. there in a normal person without symptoms, the retinaculum is very hard to see. It's very faint black hypocoque line. You just have to look in the right area. Movement sometimes does allow them to be a little bit more conspicuous. Stressing it, performing basically an isometric contraction of the finger flexors, trying to get the tendon to pop up off the underlying bone, and the normal finger will not migrate away from the bone. Here's a couple of pictures of an abnormal pulley. So in this patient was a rock climber and had a traumatic injury, and obviously even at rest, you can see the tendons here elevated off the bone by this effusion. So that's relatively easy to pick up there compared to their asymptomatic side. And then here it is, cine loop again. Under stress, you can see the tendons kind of floating there off the bone, and that would be not normal. Trigger fingers, as I noted earlier, my opinion on these is that's similar to Decker veins. It's basically an entrapment of the tendon underneath a very thickened retinaculum. So the sonographic image here shows a cross section of the tendons as well as the retinaculum. Normally the retinaculum is a very thin, almost imperceptible kind of structure. Often when they have trigger finger or thumb, the retinaculum was several times thick compared to the normal size, often like 3 to 5 times as thick when I measure these. There can be some other sonographic findings, such as a dark tendon sign, because the tendon is getting trapped, it's being turned or curved and causes anisotropy of the tendon, which causes the dark tendon sign. And then there'll be thickening of the retinaculum, as well as a reduced excursion of the tendon. So they may have tendinosis, or you'll see the tendon kind of get hung up underneath the thickened pulley, between the pulley and the underlying jointing bone, and it'll kind of get hung up, and that moves smoothly like it should. Obviously, these are more a clinical diagnosis, which are supported by the imaging findings. Diagnosis of trigger finger or thumb is not hard to make clinically. Again, luxury of a really high frequency ultrasound transducer. Here you see the retinaculum very easily. It's almost like, how could you miss that, right? But we don't have access to these high resolution transducers all the time, if ever, and it's very hard to see them on a traditional transducer. You can, beyond releasing them, you can perform a simple corticosteroid injection. So if the patient wants, I'll offer up to about 2 of these. Beyond that, I'm directing them more to get them released. But they can be approached either from a distal to proximal, proximal to distal direction, in or out of plane relative to the transducer. It's somewhat up to the person performing the procedure. There have been some studies, not with ultrasound guidance, but non-guided injections, that show if the solution is placed adjacent to or relatively superficial to the pulley, they actually do better. Obviously, sorry, this is a sonographic images showing that that process, right? So here it's moving from a distal to proximal direction. The needle's brought in underneath the pulley here, outlined in this yellow oval. And then as you inject the solution, you would see it kind of spill around the retinaculum and then fill the tendon sheath if you get into the sheath. Again, here's a couple of sonographic images of a normal and non-normal. So you can see the difference between the thickness of a normal and the non-normal sides. It's relatively, almost 6 times as thick on the non-normal side. And then a still image of an injection, again, using a gel standoff technique. The needle is coming through the gel directly down at the level of the retinaculum or the pulley there, and placing the injectate there. Traumatic injuries. Sorry, I thought I had some, must be later. I should have some images of trigger finger release, but tendon Flexor tendon injuries can occur. These are traumatic, where there's an overwhelming kind of loading of a flex digit, either rupturing the tendon directly or causing an avulsion injury. There's 5 basic types of the jersey finger, and it has to do with the level of retraction, whether or not there is a bony component to that that injury. So it's something to be aware of when you're evaluating for traumatic finger injury. Tenocynovitis, this kind of think of these in these 2 buckets. So tenosynovitis is in the sense of like an inflamed synovial sheath, and then the stenosing tendovaginosis, or this entrapment kind of phenomenon, those being the trigger fingers, declavanes, eccentric carpal nares, the intersection syndromes, or the injury to the FCR. These are more not inflamed, but more compressed, irritated tendons from being rubbed, and develop a tendinosis or tendon sheath effusions that way, as opposed to these true, what I would call true inflammatory causes, whether it's from an inflammatory arthritis or crystalline or deposition disease, or we don't really see infections so much because these usually go to the ER here in the US, but they can become infected. Again, we don't see rheumatoid arthritis too much in the US because of all the nice medications they have to control this. But if you're in an area or you have a patient that isn't using those medications, they would have really thickened, swollen appearing, mixed echogenic, usually synovial sheaths that have a lot of increased Doppler signal. If it goes on for long enough, it may cause adjacent bone erosions. And then because it can cause so much compression of the tendon, they could basically interfere with the blood supply to the tendon and make them subject to rupture. On the flexor side, it could cause compression of the median nerve, or even entrapment of these flexor tendons at the level of camper chiasm, which is the region where the FDS moves around. I'm sorry, where the FDS moves around the FDP tendon. A sonographic image at top left here shows this proliferation of the synovium. Like I said, it's kind of a mixed echogenic kind of structure. It wouldn't be pure anechoic like a tendon sheath effusion. And then if it goes on long enough, you may see some adjacent cortical irregularity in the bone. Obviously on the MRI, with much better contrast resolution and a larger kind of scope of field of view here, you see all the flexor, all the tendon sheaths are involved on the MR. Again, complications could include rupture, either from direct attritional injuries or ischemic injuries. Crystalline tendinopathies occur, so your gout or pseudo gout, as you call it, gout is monosodium urate crystals that come out of solution, are related to either overproduction or under secretion of the uric acid. Often, again, not hard to make a clinical diagnosis, usually really painful, swollen, erythematous looking, along with a history. Best diagnosed, obviously, with if you can get a fluid or tissue sample to look for these negatively birefringent needle-shaped crystals, and then treating them with either oral medications or corticosteroid injections. Pseudogout, the positively birefringent rhomboid-shaped calcium pyrophosphate crystals. Radiographically may see them, whereas you wouldn't necessarily see them with gout radiographically. And it's going to be kind of within the fibrocartilage or the hyaline cartilage, where you see them either radiographically or sonographically, whereas with gout, it sort of lines the cartilage, so you'll see this kind of dusty appearance aligning the articular cartilage. Treated similar to you would treat any kind of arthriticity. Calcific tendonitis or tendinosis, like I said, usually just involves the flexor carpal neurus tendon, more common in women than men, kind of middle-aged group, similar to all the other calcium involved tendons, the same similar age group, similar other risk factors, can be seen radiographically and could potentially be aspirated or lavaged. Deposition diseases, amyloidosis, you should think of this even in those with like carpal tunnel, right? Because it can cause infiltration of the tendon sheaths and the nerve, and give them carpal tunnel symptoms. Similar, maybe less common, achernosis, or this deposition of the homogenistic acid, again causing more of a space occupying kind of swelling of the soft tissue and may lead to carpal tunnel or trigger fingers and the like. Again, septic Tenocynovitis, I don't really see these usually get picked up pretty easily in the ER or by the primary care providers, most often related to skin flora, so staph or strep or pastula in a animal bite injury. Very painful, very swollen, usually kind of fusiform swelling. They really don't want to move the digit. It's really painful to press on, as well as have them move it or you move it. Again, on the flexor side, you can have anatomic variations with muscles. So you can have accessory FDS or gastric bellies of the FDS, which may go down into the carpal tunnel and cause compression of the median nerve that way. We discussed the presence of an accessory abductor GD minimi muscle, which overlies the Gyan canal and can cause an ulnar nerve entrapment. So you'll see these at some point in your career if you haven't already. Tumors, fortunately, there aren't a lot of malignant type tumors in the area. You'll commonly see these three types: giant cell tumor, glomus, and lipomas. So giant cell tumor of the tendon sheath, it is or is very similar to pigmented villonodular synovitis. It's often, as these sonographic images depict, a mixed echogenic kind of enlargement of the soft tissue, usually peritendinous, may, if going on for long enough, cause cortical irregularity of the bone, and they'll often have increased Doppler flow, within the lesion. Glomus tumor is an avascular malformation at the nail bed. So it'll be very, very painful, kind of growing mass there with a lot of chaotic blood flow on Doppler imaging. And then lipomas are usually more of it would be a non-painful mass that may be enlarging very gradually, can be intramuscular or, in the subcutaneous tissue, like in other regions of the body. And if they get big enough, may cause, compression of a sensitive structure such as a nerve. So that's the conclusion of the talk. I'm sorry, I thought I had some trigger finger releases in here. The trigger finger release is performed similar to that of the trigger finger injection. Instead of you can use a regular needle, but again, like the Decorvain's release, we use the no core needle and use that to incise the retinaculum of the respective digit or thumb. And again, that works really well, and it usually leads to resolution of their symptoms rather quickly. And is, once it's anesthetized, it's really not a painful process for them. So,
Dr. Troy, thank you very much for the beautiful and very comprehensive lecture. It was an excellent presentation of the wrist and hand. It's complete. I would say it covers so many things, and I really appreciate you for your time and opportunity that we can learn from you. I have a couple of questions that I would like to bring to you. Um, there are patients who are suffering from pain over the wrists joint, and usually you don't see any ultrasound findings except for the fact that maybe there could be some um, signals that would be coming from the distal branch of the posterior interosseous nerve. Would you mind sharing to you if it would be worth doing probably a block on the posterior interosseous nerve just to get rid of the pain on the wrist, or
Sure.
do you have any
Hmm.
experience with that?
Yes. So I don't do this anymore, but I used to perform radiofrequency ablation of nerves such as genicular nerves. I tried it a few times for this particular nerve, and it did not go so well. There's actually a case series of my patients where I had 3 out of 4 patients that I performed it on. I used a cold radiofrequency ablation, and before that, I performed a block of the postinterosseous nerve. You do it at the dorsal level of the radius, just under that 4th compartment where you would find the nerve, usually somewhat easily once you know where to find it and what it looks like. And they had positive blocks. I used a very small amount of that to really try to be, specific about it. But and then I did the ablation, but unfortunately, in almost every case that it went awry about 6 months after the ablation, um, they had spontaneous rupture of their extensor pollicis longus tendon, and so that was written up. I believe it's in the hand literature because that was when I was back at Michigan, and the one of the hand residents wrote that up. Um, back then. So fortunately, they were able to repair all of those tendons, and the patients went on to have no functional deficits. At the time of the surgery, they also excised that nerve and did a definitive lesion of the nerve. Often, as you know, hand surgeons will cut the nerve, right, for wrist pain or just to make sure that they don't have to go in back for wrist pain itself. So um, yeah, it is something that you can target, and but I would shy away from doing the ablations.
I see. Okay,
Yeah.
the other question that I have is, it's good that you mentioned about the brachioradialis tendon inserting into or underneath the first dorsal compartment. That was a very tricky structure, actually. And the thing is, if you see a septate first dorsal compartment, and then you have a swollen tendon right there, as in the case of the veins,
Hmm.
would you do an injection on a separate sheath, or would you just inject it right inside the common sheath?
Yeah, if they have like in this top left image that I have here, if they have a septation, then uh, I'll inject both. To be honest with you, I'll make sure, regardless, that I am filling both tendons or the fluids flowing around both tendons. Whether they have a sub compartmentalization or not, just to make sure. Um, because the theory is right for the non-guided procedures that the reason they fail was because one of the sheaths didn't get filled, right? So I'll just make sure that I do it. The other thing is I've really moved away from outside of your postpartum female, where they have a lot of pain,
Mm.
and they're going to respond well to the steroid injection. I for my patients that are more like the peri-retirement age group, I'll just try to redirect them to releasing it as opposed to injecting the steroid around it. because the release works so well and it's really easy. And I haven't really cured anybody with the steroid injections. They just keep coming back, right? Because it's not really an inflammatory problem. I don't think it's just an entrapment problem.
I see. I see. So you've cited also the different technique for carpal tunnel releases using Sonex and all those newer technologies. From your experience, which is the best among them?
The one that you can do, I guess. I mean, I think this. I've used the Sonex. I'm not currently doing that for basically because I cannot get privileges to do it where I'm currently at. It's been challenging from just a medical political standpoint to do it here, but my experience with it, it was very easy, and it was extremely well tolerated procedure. The way I do it now on select patients, somewhat kind of under the radar, is I use the no core needle, and it's tedious, and I feel like I can do such a much better job, safer for them using a dedicated device. But I have never used the thread, the surgical thread. I think that sounds intriguing, and I've never used or seen the Manos device either. I did try using a hook knife, so you can use arthroscopic tools for a variety of different things for releases. So I'll do in the lower extremity, I'll do compartment releases for chronic exertional compartment syndrome using a meniscotome. And some people use the hook knife for cutting the biceps tendon, and then I forget their name off the top of my head, but one of the authors, I think they're out of Spain, they use the hook knife, and I tried that once. That is, a hook knife is basically, looks like a fish hook that's straightened out, and then the knife for cutting parts on the back side of the hook, and you have to be extremely accurate with placement of that, because as soon as you try to pull out or redirect that, you're cutting something, and if you're a little off, it's very disconcerting. So I did that one time, and I'm not going to do that again. But yeah.
Okay,
So I
Dr.
think the ones that are designed specifically for it would be the safest and easiest.
Okay. Pash, do you have a question? Pash? Hello?
Hello, Doc. Hello.
Hiya.
Hello, Doctor. So,
How you doing?
thank you very much for this very comprehensive lecture. It was really it was very complete. I agree with Dr. Jim. So my question is, Doctor, I noticed that you tackled a lot of fluids during the lecture, but I didn't hear much about the dextrose. Is there any rule? Did you ever use it during your treatments or whenever you do releases?
Mm-hmm.
Thank you.
Yeah, you're welcome. Yeah, thanks for the question. I don't use dextrose. I've never been trained in using dextrose for like prolotherapy or something like that. So I don't have any personal experience using that.
I see. Do you use orthobiologics, Troy?
I do. I do that more for larger areas, like larger joints. I'll do it on occasion in the wrist or hand area if at the same time we're doing, let's say, their knee or something like that. It's in the US, it's patients have to pay for it, and so I guess I'm not very good at selling it for these smaller areas like the CMC joint or the like. If we're doing something that's bigger, then I'll ask them if they have other areas, because it's for us, when we do it, we don't charge anymore if we're doing it at multiple sites. So, I'll try to help spread it around for them if it's appropriate. But that I don't do a ton of it in the wrist or hand area.
I see. So Dr. Troy, thank you very much. And I appreciate you for all your time and your effort and for that excellent talk. Very
You're
nice,
welcome.
very comprehensive, and looking forward to doing more things with you and
Yeah, sounds great.
inviting
would-
you to write a chapter again in our new book. So thank you very much, and
You're-
keep safe.
All right, you too. Thank you for the invitation. Looking forward to more of these with you.
Yeah, God bless.
All right. Have a good night or good day.
Good night, good day.